Good morning. Welcome to today's live broadcast, Reconceptualizing Genital Herpes. I'm Edward, or Ned Hook, from the University of Alabama at Birmingham, and I will be both moderating and delivering today's presentation. We're delighted to bring you this educational web seminar presented by LabRoots and sponsored by Roche Diagnostics. For more information, please visit labroots.com. We have a few important announcements before we begin. First, the webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit your questions by typing them in the Q&A box, which can be found by clicking on the screen Q&A button on the lower left of the presentation window. We'll try to answer as many questions as possible after completing the presentation. You can enlarge your slide window by clicking on the screen icon in the lower right-hand corner of the slide window. Finally, if you have any technical problems viewing or hearing the presentation, please click on the support button at the top right-hand side of the presentation window and submit your problem through the green Q&A button lower left. Now, let me tell you a little bit about myself. I went to medical school at the Cornell University School of Medicine, subsequently trained in internal medicine and infectious diseases at the University of Washington and in Seattle. I've had faculty positions at the University of Washington, Johns Hopkins University, and now for over 2 decades at the University of Alabama at Birmingham. Throughout my career, I've focused on the study of sexually transmitted infections. Currently, I'm the director of the Division of Infectious Diseases at the University of Alabama at Birmingham. I also have positions in the departments of microbiology and epidemiology. My research and work has focused on sexually transmitted infections, including genital herpes, for over 25 years. I hope that the information that I'll be providing will be useful to you, and it reflects changes in the way I've come to think about this disease over time. I also have the honor of serving as an expert member on a number of federal and international guidelines, committees, and advisory panels. This includes being a member of the CDC's recent STD treatment guidelines review panel. That document was released in June of 2015. So with that as background, let's go on and start with our presentation. I've called this presentation Reconceptualizing Genital Herpes, and it reflects both emerging concepts and changes from the way all too many of us used to think about this disease, as well as some controversial issues. Before I actually start, let me present to you my own issues regarding my disclosures. As you can see from this disclosure slide, I have worked with NIH, CDC, the World Health Organization, and a number of industry sponsors. Those industry sponsors have given me access to new information and new tests which have shaped what I've done, but I do not believe that they are going to change my presentation today. Of course, you will be the judge of that. Genital herpes is a larger problem than many people expect or believe. If we look at this slide, which represents office visits for genital herpes, we can see that over the past 2 decades, these office visits have steadily increased over time. Furthermore, we now know that while many people are not aware of it, the overall prevalence of genital herpes is no less than 16%, and that's just for genital herpes type 2. As we'll talk about in just a moment, genital herpes is caused not only by herpes simplex virus type 2, but also herpes simplex virus type 1. But what makes genital herpes important? Is it the signs and symptoms of disease? I would argue that that's not the case. Certainly, those are an inconvenience and a problem for people who have it. But in fact, I would list the other 4 items on this list as the major morbidity associated with genital herpes. That includes that anybody with genital herpes, if exposed, is at increased risk for acquiring HIV. In addition, because of the stigma associated with this disease, a diagnosis of herpes can be emotionally traumatic and difficult for our patients to handle. Like any sexually transmitted disease, its consequences are amplified by the fact that the disease can be transmitted from one person to another. And then finally, and sadly, this is a disease which is occasionally transmitted by infected women to their children at the time of birth. Congenital herpes can be devastating for those children, leading to lifelong consequences. So let's start with the way we used to think about herpes, and I hope that this will not be the way we think about it going forward after this presentation. When I was taught first in my infectious disease training about genital herpes, I was told that genital herpes was easy to recognize, that people had characteristic blisters and similar issues. Secondly, I was told that most people who have genital herpes already know that they're infected because they recognize the signs and symptoms of infection. I was also taught and told my patients that if they didn't have lesions, they didn't have to worry because genital herpes was transmitted only by direct contact with an infectious lesion. And because at the time I was in training, the first treatments for genital herpes were becoming available, I was also taught that while treatment did not cure this lifelong disease, it did cause more rapid resolution and diminution of the pain associated with the disease. I'm here to tell you now that each one of those previous perceptions, which still remained all too common, were incorrect, and would like to go through those data over the next few minutes with you. Let's start with the issue of how common genital herpes is and who had it. Described on this slide is a landmark study done in Seattle almost over 2 decades ago, in which almost 800 women presenting to their sexually transmitted diseases clinic were evaluated. They asked every patient whether or not they had genital herpes or not, and then they tested them using sophisticated blood tests to detect antibodies to the virus. They examined the patients for evidence of lesions. They asked history as to whether the patients had recurrent lesions or not. And using those methods, they found that while only a small proportion of people knew that they had genital herpes, the fact of the matter was almost half of patients, female patients attending that clinic, had some evidence of genital herpes. Amongst the nearly 50% of women who had some evidence of genital herpes, about 1 in 5 did have clinically recognized lesions. That makes sense. That's the reason they were attending the clinic. But the other 4 out of 5 patients with genital herpes had other manifestations. Another almost 1 in 5 gave a history of having had recurring genital lesions in the past, again suggesting genital herpes. So we can take those 2 groups and say those are people who either knew or would have found out they had genital herpes. But the majority of patients in this study did not know they had genital herpes, gave no history. Yet, excuse me, about 2% of the women with herpes, or almost 5% of the group of women with herpes overall, had asymptomatic shedding of the virus. That is, the virus was present on skin in which lesions weren't present. We'll talk more about asymptomatic herpes in just a moment. And then finally, almost 30% of the overall population, that is, almost 2/3 of the women who had evidence of genital herpes, had antibodies to herpes simplex type 2 virus, the virus that causes much but not all genital herpes. These women were also unaware that they had the infection. Thus, even in this early study, which has been replicated many times, we could say for sure that the majority of people who have genital herpes are not aware of their infection. What about other perceptions? We've already begun to establish the fact that most people with genital herpes know that they're infected as a misstatement and an incorrect belief. We also are fond of thinking of the people who have genital herpes as being more like the group of patients on your right than those of us on the left who are caring for these patients. That is, people with genital herpes are somehow out of control, misbehaving, doing wrong things that lead them to get infected. As we'll see in just a moment, that is not the case. These are data from several national studies which are representative of all citizens, all adult sexually active Americans. They're based on carefully conducted interviews in communities across our country. In the first study, they ask, and again, this has been replicated many times, they would ask, using trained interviewers, do you have genital herpes? Has anybody ever told you had genital herpes? And overall, in the American adult population, about 1 in 50, or 2% of Americans, are aware that they have genital herpes. In the same sorts of nationally representative studies, however, if they do antibody tests looking for herpes simplex type 2 virus, the virus which causes much but not all genital herpes, in 1978 we found that about 16% of the general population had antibodies to the virus that causes genital herpes. Antibodies indicate that these people do have the infection. By 1990, that number had increased by almost 30%, so that now nearly 22% of Americans had antibodies to genital herpes type 2, or the herpes virus type 2, the virus that causes most genital herpes. If we include the proportion of genital herpes that is caused by herpes virus type 1, it's very safe to say that over 1 in 4 adult Americans who are sexually active has genital herpes. So here's the situation. Nearly 1 in 4 Americans has the infection, but only 1 in 50 knows it. That's a problem because people who, as we'll see in a moment, people who are unaware of their infection still are at risk for transmitting the infection to others. These data are similar. They increase and show that genital herpes rates tend to go up over time depending on how many sexual partners a person has had or by their race. And sadly, genital herpes is once again an example of health disparities in which rates of genital herpes is higher amongst Black Americans than it is in whites. That is not because of susceptibility or behavior. It probably has more to do with access to care. We can deal with more about that in the Q&A period if you'd like. The next slide, however, is a particular favorite of mine. The first point in this slide should not surprise you. What this slide shows on the x-axis is the number of sexual partners that each respondent had. And on the y-axis, it shows the proportion of those people who had antibodies to herpes simplex type 2, the virus that causes most genital herpes. It should not be surprising that people who had more partners tended to have higher levels of antibodies. But there are 2 other surprising and informative points on this slide. The first is in that group of overachieving individuals who had more than 50 lifetime sexual partners, only 40% of those individuals had acquired genital herpes. This reinforces the fact that not everybody with lots of sexual partners necessarily has the infection. The second, and perhaps even more important point, is on the left-hand side of the slide. And as you can see in the red bar, about 8% of Americans who have only had a single lifetime sexual partner still have evidence of having had genital herpes type 2. Thus, about 1 in 12 Americans with only 1 lifetime sexual partner turns out to have genital herpes. You might ask, how can that be? And once again, let's remember that this is an infection which is passed from one person to another, so that individuals are at risk not only because of their behavior, but also the behavior of their sexual partners as well. So I think we can now say that the statement that most people with genital herpes know that they're infected is simply wrong and incorrect. It becomes important for laboratorians to provide tests who can help their healthcare providers do a better job of finding this all too common disease. Let's go on a little bit and examine the fact that perhaps genital herpes is easily recognized. That too turns out to be incorrect. The simplest way to state this is that classical genital herpes is not typical genital herpes. What I mean by that is that this all-too-common disease has a variety of different presentations for individuals. So that across the United States, the most common cause of genital ulceration in adults is without doubt genital herpes. Less common causes include syphilis, chancroid, trauma, other sorts of infections. To emphasize this point, I'd like to tell you about a study that was performed, once again, almost 2 decades ago by the CDC, in which over 500 patients were recruited from sexually transmitted infection clinics in the 10 U.S. cities with the highest syphilis rates. The purpose of this study was not to study herpes, but to study syphilis and the possibility that there might be increased numbers of cases of chancroid that were being missed in the country. As a result, in this study, specific efforts were made to exclude patients with genital herpes. Patients did not take part in the study if they had typical appearing genital herpes, if they gave a history of recurrent lesions, if they'd been a sexual partner recently to a person with genital herpes. As you can see from this slide, however, despite efforts to exclude those people who logically and typically had evidence of probable genital herpes, over 2/3 of the patients in this study turned out to have genital herpes. 62% had genital herpes as the single lesion present in their genital herpes. Another 3% had a combination of herpes and syphilis at the same time. It's these sort of data that allow us to say when a patient walks into your clinic with a classical lesion of syphilis or a typical genital ulcer, it's still, no matter what you think it might be, most likely to be genital herpes. What might herpes be mistaken for? Well, it's also important to realize that many of our patients don't find a lesion somewhere in their genital area and say, oh, wonderful, I probably have genital herpes. So despite the fact that the most common cause of almost any genital lesion occurring between the navel and the knees is genital herpes, people find other explanations for what might be going on. If we ask patients, they might say, gee, I thought I had a yeast infection. And there's some logic to that. After all, they had soreness, they had irritation, they applied yeast medication, and after a few days, the lesions went away and the soreness went away. Well, turns out that may not be a yeast infection. Other patients wonder if they might have folliculitis or heat rash, or if their clothes might be too tight, or if they'd spent too much time on an exercycle or other exercise, or if their sex had been too vigorous, or if they'd been shaving, or my own personal excuse limited to men is the apocryphal story, gee doc, I think I have a zipper cut. I'd like you to think just how hard it is for a man to repeatedly get his penis caught in his zipper. So what I'd suggest is that it's important to realize that when a patient has a genital lesion, herpes is on the differential diagnosis and in fact may be the most likely cause, no matter how it appears. So how should we treat our patients? Well, if the lesion looks like herpes, we should treat it as herpes. If it looks like syphilis, we should treat it as syphilis. But if we want to do the best thing for our patients, we do owe them the opportunity to test to see if, in fact, it might be herpes and that our diagnostic efforts on the basis of history and appearance alone might be incorrect. So, having said and having hopefully established that clinical diagnosis is rather insensitive and nonspecific, let's talk about what we can do to better diagnose this common infection. I would suggest that there are 2 ways to approach the diagnosis, and it depends on who the patient is and what the clinical setting is. One approach is virologic, that is, demonstration of the virus itself. The other is to do blood tests looking for herpes simplex type antibodies. So, what tools do we have for diagnosing herpes? For direct demonstration of the virus, tissue culture used to be the gold standard for diagnosing the infection. In fact, the CDC guidelines suggest that that may still be the case. However, I would suggest to you that now with new commercially available polymerase chain reaction, or PCR type tests, we have a diagnostic test which is about 30 to 40% more sensitive than tissue culture, particularly for patients with recurrent lesions, and should be the emerging gold standard for diagnosis of the infection. We also do have serologic tests, and I'll comment on them and their use in just a moment. But first, let's talk about virologic tests. Remember that viral culture is only as good as the culture situation and setting. So if transportation issues limit getting the specimen to the laboratory, if it's a recurrent lesion, if it's a healing lesion, all of those things make it less likely that your culture results will be positive. On the other hand, PCR has fewer transport limitations, is far, far more accurate, and provides rapid type-specific diagnosis, and gives clinicians the ability to accurately differentiate between herpes simplex type 1 and herpes simplex type 2 as the cause of their patient's genital lesions. These are important data for patient care. Furthermore, as I've already said, atypical lesions may occasionally be mistaken for other things. This picture shows herpes simplex lesions on the buttock. And I would wish I had a quarter for every time a patient had come to me and said, gee, I have recurring herpes zoster which occur on my rear end or on my leg. And indeed, these lesions do look somewhat like herpes zoster. It reminds us that when these lesions occur in different locations, like the leg and like the buttock, they may indeed mimic other more common viral diseases like herpes zoster, and that a culture is the way to differentiate. It also reminds us that herpes zoster is rarely a recurring disease. This next slide shows our friend the cold sore. And it's important to also remember that over 60% of American adults are infected with herpes simplex virus type 2. In the majority of those individuals, that's because they have oral labial herpes, which may or may not cause cold sores. Many patients can have herpes simplex type 1, however, and not be aware that they have it and not have cold sores. However, in the performance of oral sex, these infections can be transmitted to cause genital ulcers. An increasing proportion of genital herpes in the United States is now caused by herpes simplex type 1. And that's an important distinction to make, because as we'll talk about a little later, we treat genital herpes simplex type 1 differently than we treat genital herpes simplex type 2. So that knowing which virus is causing our patient's genital herpes is an important management question and contributes and shapes the way we manage patients with genital herpes. Furthermore, recent data have shown that the natural history of herpes simplex type 1 and herpes simplex type 2 in the genital area are different. In this particular study described in this slide, as you can see, while about 15% of genital herpes was caused by herpes simplex type 1, the recurrence rates for genital herpes type 1 were far lower than the recurrence rates for genital herpes type 2. That's very important when we consider whether or not we're going to place our patients on suppressive therapy to prevent recurrent genital herpes. If a patient's chances of recurrence are only 1 in 50, we may not want to prescribe long-term medication to suppress those rare events. Let's turn to serological tests, and I suspect that this slide is difficult for you to read. It's really, you can look at it later on the web if you wish, but it lists the increasing variety of serological tests which provide testing for type-specific antibodies. That is, they do a good job of differentiating between herpes simplex type 1 and herpes simplex type 2. These tests, however, are unfortunately not perfect. In the past, there were antibody tests for herpes simplex which were not type-specific. So if you're ordering blood tests for herpes, it's important to make sure that the test you're using is based on the herpes GG protein. This is the type-specific protein that allows differentiation of one viral type to another. Second, IgM tests are not useful for diagnosing a genital herpes infection. They are nonspecific, and IgM tests both often have false positives and do a poor job of differentiating herpes simplex type 1 from herpes simplex type 2 infections. The CDC treatment guidelines specifically recommend against ever using IgM tests for serologic diagnosis of genital herpes. Third, the presence of antibodies to herpes simplex virus type 2, if it is a true positive, clearly represent anogenital infection. Herpes simplex type 2 is a very, very rare cause of oral herpes and cold sores. Thus, if a person has antibodies to herpes simplex type 2, the clinician or laboratorian can say with great confidence that this infection is almost certainly due to genital herpes. Finally, the presence of antibodies to herpes simplex type 1, on the other hand, does not distinguish between anogenital infection and oral infection. That's because many patients can have oral or oral labial infection even without cold sores and have antibodies to the virus. As we've also mentioned, however, an increasing proportion of patients with genital herpes now have it due to herpes simplex type 1. So the antibody test is helpful, but only helpful so far. This slide tells you a little bit about the issue of antibody detection, how quickly tests become positive, etc. What I'd like to emphasize for you here today is that in general, it takes several weeks and sometimes several months to develop antibodies. In fact, at 3 to 4 weeks, only about half of patients with recently acquired genital herpes will have positive antibody tests. So the antibody test is not usually going to be positive in patients who are presenting with the first onset of new lesions as possible genital herpes. On the other hand, if antibodies are present at the time of first presentation, it is likely that you're dealing with a more established infection. In some patients, it can take as long as 3 to 6 months to develop genital herpes. The majority of patients will develop antibodies, however, within 3 months of their acute presentation with first episode. Unfortunately as well, there are occasionally false positives with these antibody tests. This slide describes the rates of positivity in patients who could be shown to have herpes using the numerical values that are reported out as positive the test with the Focus herpes select test, one of the more widely used tests for herpes antibodies. As you can see, the higher the number going from left to right, the more likely it is that that person truly has genital herpes and does not have a false positive result. Thus, while the package insert will inform you that a positive result can occur anywhere from a person with a value of 1.1 or higher, the fact of the matter is that false positives do occur typically until patients have levels of above 3 in their EIA tests. Thus, the numerical value and the height of that numerical value may help you to determine whether, in fact, your patient truly has genital herpes or not. This cartoon by Larson et al. Then reminds us that it's now time to talk about herpes transmission. As you can see, here's a young man who's just met this woman at a bar, and he's commenting on how nice her eyes are. Meanwhile, and he's saying, "Your eyes are so nice. Oh, and you're from Paris." Meanwhile, his herpes viruses are saying, "Oh boy, we're going to Paris." So let's talk a little bit about herpes virus transmission. It's been said in the past, and it's still, unfortunately, widely said, that genital herpes is usually transmitted by direct lesion contact. Unfortunately, that statement is incorrect. We've learned much about the transmission of genital herpes from studies of herpes vaccines, that is, vaccines which were designed to prevent people from getting herpes. Unfortunately, those vaccine development efforts have not yet been successful, so we don't yet have a vaccine. But the study design has told us much about how this virus is transmitted from one person to another. This slide was amongst the first such studies to be conducted. The way these studies are conducted is that couples, not individuals, are recruited. One person is known to have genital herpes. The other person is known not to have genital herpes based both by history and blood test results. Then, both members of the couple are informed that one person has herpes, that they should use condoms for all sexual activity, that they should avoid sexual contact if lesions are present. And, unfortunately, despite that counseling, over the course of the next year or so, about 1 in 10 of those couples will lead to transmission of infection from one person to another. In this particular study, transmission events were then analyzed, and analysis reminded us that transmission of this infection is more efficient, that is, more likely to occur when it's the male partner who has genital herpes than when the female has genital herpes. It also suggests that people who already have antibodies to herpes simplex type 1 are less likely to acquire herpes simplex type 2. Thus, this suggests that antibodies do offer some, but not by no means absolute, protection from infection. But for me, the most important observation in this particular study is that of 13 couples in whom transmission occurred and their diaries allowed people to think about whether lesions were present or not, in 9 out of 13 instances, the individual who transmitted the infection was asymptomatic at the time of transmission. Thus, we can say now that without a doubt, most transmission of genital herpes occurs when symptoms are absent. Remember as well that this particular study was done in the ideal situation in which the couple knew that one person had genital herpes, whereas in the real world, as we've already discussed, most people are not aware of their infection. As a result, we can say that without a doubt, most genital herpes is now transmitted by people who do not know that they have the infection. So, to summarize what we know about anogenital transmission of genital herpes, we know that certain sex acts are more likely to transmit than others. For instance, being the receiver of vaginal insertive sex is more efficient than for the male. Receptive anal sex also is more effective for transmitting infection than being the insertive partner. And oral sex can lead to transmission of genital herpes type 1, or oral herpes to cause genital herpes type 1. We also know that sexual transmission of this virus is greater from men to women. And fortunately, we know that over time, and we're talking about a time period of months to years, the likelihood of transmission tends to decline with increasing duration of infection. But what about asymptomatic viral shedding? What we're talking about here is not people who are unaware of their infection and have some of the things that are mistaken to be other causes, but people who truly have no lesions. And what we know that in the absence of genital lesions, people do regularly shed the virus. Asymptomatic shedding can occur almost anywhere in the genital tract. That is, the vulva, the perianal region for women, and men on penile skin, and also around the rectum. Asymptomatic shedding rates are highest within the first 3 months of infection, and then gradually decline. However, even people who've had their infection for many years can have asymptomatic shedding of the virus. how common is asymptomatic shedding? Well, the best data from that are from studies done at the University of Washington evaluating women who were pregnant and who were screened for blood tests with blood tests for the herpes viruses. In these studies, of almost 4,000 women studied who had antibodies to herpes simplex virus type 1, only 2 women were asymptomatically shedding. Okay? That's 5 out of 10,000 women were asymptomatically shedding herpes simplex virus type 1. On the other hand, asymptomatic shedding of herpes simplex virus type 2 was far more common. Of the 2,400 women who had antibodies to herpes simplex type 2, when studied and tested for asymptomatic shedding, 1 in 50 of those women, over 2%, were asymptomatically shedding the virus. So once again, we've emphasized that it's important for our patients to know precisely which virus is present in their genital herpes, because asymptomatic shedding, and therefore the likelihood of transmission to uninfected partners, is less for people whose genital herpes is caused by genital herpes type 1 than it is for genital herpes type 2. Let me once again emphasize that I said less, not absent, so that certainly genital herpes type 1 can rarely be transmitted from person to person. But most genital-to-genital transmission of herpes virus is due to herpes simplex type 2. That, in turn, affects our management strategies for the virus. This slide emphasizes the point that irrespective of how commonly patients are shedding the virus, irrespective of how commonly people have recurrences of their infection, asymptomatic shedding occurs. The previous slide, this slide, talking about asymptomatic shedding in pregnant women, used culture to detect the herpes virus. When we use more sensitive tests, the PCR tests that I mentioned earlier, we see that actually asymptomatic shedding rates are considerably higher, somewhere in the 8 to 10% range in people who have a history or antibodies to herpes simplex type virus. Antibodies to herpes simplex viruses. We also see that whether they are in the group who have 1 to 3 outbreaks, or if they're in the group who have 4 to 9 outbreaks per year, their shedding rates are similar. Thus, asymptomatic shedding of the virus is a fact for virtually everyone who has genital herpes. What factors affect that? Well, as we've already discussed, viral type is an important determinant of asymptomatic shedding. For individuals with genital herpes type 1 causing their genital herpes, herpes simplex virus type 1 causing their genital herpes, they have significantly less asymptomatic shedding than people whose genital herpes is caused by herpes simplex virus type 2. Secondly, both how recently and the severity of their first episode do affect acute asymptomatic shedding. More recent first episodes of genital herpes, more recent acquisition is associated with higher asymptomatic shedding rates. Finally, host immune status also affects this. Thus, immunosuppressed hosts, and the best studied of that group are HIV-infected patients, have higher rates of asymptomatic viral shedding than people who have normal immune function. But let's remember that HIV-infected patients are no longer the individuals who are asymptomatically shedding the virus and who are at risk for increased asymptomatic shedding. This might include people who are on chronic steroids, who are taking immunomodulators to deal with other chronic infections, the so-called TNF inhibitors, so that people whose host immunity has been compromised either by disease or by other therapeutic agents do have asymptomatic shedding of the virus. Another important question is, how do people acquire the virus? And it used to be thought that nearly everyone who acquires genital herpes will have a symptomatic outbreak as their first evidence of infection. Again, learning from recent vaccine studies of the virus, we've learned that that is not the case. That in fact, somewhere in the neighborhood of half of patients who acquire genital herpes may acquire it in a subclinical fashion. By subclinical, I may mean that they miss the lesions or present, or that their acquisition is truly asymptomatic. Irrespective of how they acquire their infection, people who are not aware of their infection still do have asymptomatic shedding of the virus. It's also important to emphasize that this business of people acquiring the infection and not being aware of it is more common for men who acquire the infection than it is for women. Finally, let's turn to the issue which is important for our patients. What about treatment? In the past, it was said that herpes treatment can only benefit patients in terms of helping to resolve lesions more quickly and shortening the duration of symptoms. That, too, is no longer the case. So once again, referring to our Larson cartoons, the management of our patients who we diagnose genital herpes is not as simple as the textbook suggests it is for taking care of a sick horse. As you can see from this cartoon, whether your horse has a broken leg or just bad breath, there's only one treatment: shoot them. On the other hand, our management of patients with genital herpes needs to be far more nuanced. We'll talk just in a moment about the important role of systemic antiviral chemotherapy for our patients. But I'd also like to comment for a moment about counseling. Counseling is an important part of our management of these infections, and often that requires repeated efforts to counsel patients, because sometimes the shock of initial diagnosis prevents people from hearing our counseling messages. Counseling should include a description of the natural history of the disease, that transmission typically occurs by people who are unaware of their infection, that perinatal transmission, that is, transmission by infected mothers, is a very rare event, but something to be considered, and therefore women who are infected need to share this information with their OBGYNs. And that there are a number of methods in which we can reduce transmission, including condom use, avoidance of sex during lesions, and, as we'll talk about in a moment, antiviral therapy. So let's now turn to antiviral therapy. Oops, I'm sorry. I think I've just commented on this. Please feel free to go back to this slide, and let's turn to the issue regarding treatment. In the 2015 CDC treatment guidelines, there are 3 principles of herpes treatment which are important to emphasize. First, topical therapy is of little benefit to patients. The cost of topical medications is similar to the cost of the generic antiviral therapies that are available in oral formulation, and oral and IV therapies work better than topical therapies. Second, careful discussion of suppressive therapy is important for our patients with genital herpes type 2, but perhaps not for patients with genital herpes type 1. And then finally, over time, our treatment measures have changed so that we now more and more use shorter durations of therapy for our patients. Currently, there are 3 antiviral medications that are widely available in the United States and used. All of these work in a similar fashion by inhibiting viral thymidine kinase. These include acyclovir, valacyclovir, and famciclovir. For patients with their first episode of genital herpes, the following treatment recommendations are recommended: 7 to 10 days of therapy with varying doses of either acyclovir, famciclovir, or valacyclovir. These can be looked up. They're highly effective. They do shorten the duration of initial outbreaks. They do improve the resolution of any discomfort associated with the lesions, and so they're helpful. I won't go into more detail about this because I also want to really spend a few minutes emphasizing the potential benefits of suppressive therapy. We know that patients who take suppressive therapy, that is, take one of those antiviral agents on a daily basis, irrespective of the presence or absence of lesions, will have fewer symptomatic recurrences. They will have reductions in their asymptomatic shedding. And recent studies show that this reduction in both lesions and asymptomatic shedding will reduce transmission of infection to uninfected sexual partners or to children born to infected mothers. Thus, we have 4 different regimens recommended by the CDC for treating people who are undergoing suppressive therapy. That might be twice daily in dosing of acyclovir or famciclovir, or once daily dosing of valacyclovir. The doses are on the slide. All of these are similarly effective in our patients for reducing outbreaks, asymptomatic shedding, and transmission. This slide makes the same point, showing the results of a clinical trial that was performed, once again, using this partner model in which one person had herpes and the other person didn't. In this particular partner study, half of the patients received placebo, and the other half received valacyclovir. And as you can see, in the patients who did not take valacyclovir on a daily basis, over the 9-month study period, about 3.5% of individuals acquired herpes. On the other hand, for individuals who did take the active antiviral agent, that transmission rate was reduced by slightly over 50%. So while it did not entirely prevent transmission, it did reduce it. This slide in words describes pretty much the same result. It's important to also emphasize that this study was, again, conducted in large numbers of individuals, nearly 1,500 couples, in which one person had genital herpes, the other person did not. And again, this reduced the risk of transmitting infection from one person to another by over 50%. This slide shows that the effect of suppressive therapy preventing transmission to susceptible partners is active over long periods of time. This study went out for 240 days. People have continued to use suppressive therapy for long periods of time. Package inserts typically recommend suppressive therapy for about a year at a time, but many clinicians have used suppressive therapy for periods far longer than that, with good tolerance by their patients and with continued benefits from suppressive therapy. So this is my final slide, and I hope it summarized where I believe we've gone. Once again, the cartoonist Larson has helped me to express my thoughts about this. What we have here on this slide is 2 cavemen who are working out the principles of how to trap saber-toothed tigers. As you can see, they have many of the initial concepts. They have the idea of bait for their trap. They have a release mechanism, so they don't have to be there themselves to release the trap. They're just working to put the pieces together. I would suggest that as we begin to shape our reconceptualization of genital herpes, we're in the same boat. We can, through adopting these new and evolving approaches to genital herpes management, we can help our patients with and without infection. So with that, I'll thank you for your attention, and we'll turn to the Q&A period. Thanks very much for your attention today. I hope you have questions that I can answer, and I'll be happy to answer them at this time. So we're looking for questions and answers. Many people will ask questions for me, for instance, of, gee, what about pregnant women? Should we be doing blood tests on all pregnant women to see if, in fact, they might have genital herpes or not? That's highly debated. There are some experts who feel that blood testing plays an important role in identifying at-risk women. Other experts feel that this knowledge, that is, that people have infections and are otherwise unaware of their infections, that the knowledge to a pregnant woman that she might have genital herpes is simply too traumatic for many patients. I'd love to have other questions. Any questions that come up that don't start with, could I ask you about a friend of mine, would be welcome today. Let's all remember how you can submit your questions. You can submit your questions by typing them in the Q&A box, which is found by clicking on the green Q&A button on the lower left corner of the presentation window. We'll try to answer as many questions as we are. Here's a question from Eduard Lobos. Could you briefly comment on the current development of vaccines against herpes virus type 2? Thanks very much for your question. That's a great question. The concept of developing a vaccine for herpes is certainly supported by the fact that we know that people who have antibodies to one herpes virus are less likely to acquire it again. Parenthetically, I would add that that also provides us with information that many people don't get infected with herpes typically more than once. So that if somebody has, for instance, herpes simplex type 1 at their mouth and experiences cold sores, they are unlikely to acquire genital herpes due to herpes simplex type 1. So that the antibodies do protect against the same sort of infection. And they offer, as we mentioned earlier, some degree of cross-protection for the other type of herpes simplex type virus. But what about the question of vaccine development? Currently, all current efforts to develop a preventative vaccine have been unsuccessful. There have been at least 3 different efforts to do this. Research efforts funded by the National Institutes of Health, as well as a number of startup companies are ongoing. More recently, however, at scientific meetings, several companies have reported beneficial effects of a therapeutic vaccine for genital herpes. Those vaccines, which are still in development, and as I understand it, may be soon to enter phase 3 trials, have been given to patients, and in early trials suggest that by giving these therapeutic vaccines, they can reduce the frequency of recurrences and perhaps reduce the frequency of asymptomatic shedding of people who have infection. So that while preventative vaccines are not currently available, on the horizon we do have hope for a vaccine which could be used therapeutically. Okay. We have another question that just popped up from Wakefield Hospital. That question is, what test would you order first to confirm clinical suspicion of genital herpes in a young patient with no previous diagnosis of herpes? Great question. Thank you very much. I think the test of choice and the test that we use preferentially for diagnosing people presenting with concerns about lesions or presentations of genital herpes is a PCR test. These tests, taken with swabs, and I should emphasize that the swabs can even be done on dry lesions. They don't have to be vesicular or wet ulcers. Even swabs from dry lesions may often be positive in patients who turn out to have genital herpes. So that rather than using a culture test, we prefer PCR. PCR tests are typically available and the results are available the next day. Furthermore, they accurately distinguish between herpes simplex type 1 and herpes simplex type 2. I think the use of serological testing is more limited. Here's another question that's just popped up. Please, what do you mean by the symbol OP on the treatment table? OP. Let me go back to that slide and see if I can call up precisely what is meant there. let's see. Still back a ways. Let's go. I'm looking for the word OP, and I do not see it here. Oh, I think I believe that this is the question that is mentioned. So, and I apologize for using medicalese on this. That says QD, or once daily dosing. So that for suppressive therapy, acyclovir and famciclovir are recommended to be given twice daily for patients who are receiving suppressive therapy, while valacyclovir, which has a little longer therapeutic half-life, can be given once a day for suppressive therapy. I apologize to you for not spelling that out when I presented it the first time. Thanks so much for the question. Obviously, the ability to use a medicine once a day does have a convenience issue for many patients. And so that when it's possible to use that, many providers do like the valacyclovir regimen simply because they can use the medication once a day. Good question, and once again, I apologize for not having been a little bit clearer on that. We have a few minutes left for additional questions. Here's a question from John Zhang. What is your perspective view of application of next-generation sequencing in the diagnosis of genital herpes? So next-gen sequencing represents another advance for microbiology. It allows us to provide insights into the actual structure and even differentiate one kind of virus from another. For most settings in clinical management, current PCR-based tests, which simply differentiate from herpes simplex type 1 to herpes simplex type 2, are probably sufficient and adequate, and next-gen sequencing adds only a modest amount to that. Where next-gen sequencing may become important in the future has to do with the diagnosis of possible resistance to the antiviral agents that we talked about earlier. There are a small proportion of herpes simplex type viruses that have mutations in their thymidine kinase, which make them resistant to acyclovir, famciclovir, and valacyclovir. That form of resistance could be detected by next-gen sequencing and might be useful and helpful. But for most diagnostic methods, for most patient management questions, next-gen sequencing probably adds little to the commercially available PCR tests. Thank you for that question. Certainly these new molecular diagnostic tests have changed our life. As I said, the herpes PCR-related tests have been a great step forward over culture. And who knows what next-gen sequencing will bring us in the future. I see that our hour is beginning to draw to a close. I want to thank all of you for your attention today, and I hope that the information that I've provided has been useful for you. If someone has one last question, well, they can probably sneak it in. If you don't, again, I'd like to thank you for your attention. If there are no other questions, I'd like to thank both LabRoots and Roche Molecular for allowing us to bring this presentation to you. This webcast will be available for on-demand viewing through for a period of the next 6 months. You will receive an email from LabRoots alerting you to when the webcast is available for you for replay and revisiting. And we invite you to forward this announcement and the access to the webcast to your colleagues who did not have the time or availability to join us today. So again, this is Ned Hook from the University of Alabama at Birmingham. I want to thank you so much for your attention today. And with that, we'll close. Have a nice day.